Hi, I'm Isabella Zaniletti, and I'm a biostatistician at Mayo Clinic. In this video, I'm going to review the most common study designs in orthopedics. Study design is fundamental to investigate questions that arise from orthopedic practice. The choice among alternative study designs is determined by feasibility constraints and the research questions. There are two broad categories of study design available to total joint arthroplastic researchers: experimental and observational. In experimental studies, researchers actively assign the exposure or treatment to a group of surgical patients. They follow them up over time and measure the effect of treatment on the outcomes of interest. In contrast, in observational studies, we identify surgical patients either prospectively or retrospectively based on their exposure or outcome status. Then we simply collect data on them without any active intervention on their care. Let's talk about experimental studies first. The gold standard of experimental studies is the randomized controlled trial. In this type of design, treatment or placebo are randomly assigned to patients. This allows the groups to be balanced with respect to both known and unknown risk factors. There are pros and cons to experimental studies. Pros include the hypothetical elimination of confounding and the reduction of selection bias. On the other hand, clinical trials can be hard to use because of ethical and financial concerns, or patients' or surgeons' preferences for surgery, implant type, approach, or other interventions, controversial use of placebo surgery. Finally, clinical trials can be hard to implement in arthroplasty patients because randomization is not ethically possible. For instance, when blood transfusion or antibiotic prophylaxis are involved. Clinical trials are either explanatory or pragmatic. Explanatory trials include a small number of patients and strict eligibility criteria. The primary purpose is to test the efficacy of the intervention in an ideal setting. In contrast, pragmatic trials investigate the effectiveness in real-world practice. Patients are typically randomized at the group level, such as hospital level, instead of patient level. Clinical trials are still the gold standard for study design. Although they are not common in orthopedics, pragmatic trials have been object of growing interest in most recent years. And now let's review observational studies. Observational studies are either prospective or retrospective. In prospective studies, data are collected concurrently as they are measured. In retrospective studies, such as registry-based studies, for instance, the data are collected after they occurred. The most common observational studies are cohort studies, case control studies, and cross-sectional studies. Let's see each one individually. Registry-based studies in orthopedics are frequently performed as cohort studies. Cohort studies collect repeated measurement for each patient at various time points, allowing for longitudinal analysis. They are typically not subject to recall bias, but more likely to selection bias. In fact, it can be challenging to obtain a surgical cohort that is perfectly representative of the target population. For example, a surgical cohort study that is restricted to elderly Medicare patients is not representative of the younger patients whose underlying surgical indications, implant types, or comorbidity profiles are different. Even registry-based cohort studies can present limitations such as large statistical power, incomplete mortality or follow-up data, and absence of important confounders and mediators. Case control studies are efficient study designs in the setting of rare outcomes, such as cancer or hard-to-identify exposures, as for instance genotypes. In orthopedic research, matched cohort studies are sometimes incorrectly labeled as case control studies. If a study begins with exposure and follows patients for a few years to measure, let's say, revisions, it is a cohort study. By contrast, if a study begins with revisions and look back in time for an exposure, then it's a case control study. There are steps to follow when designing a case control study. First, explicitly define the sampling frame and the eligibility criteria for cases. Second, identify controls from the same source population or sampling frame as the cases. Finally, gather information about past exposures using a survey or interviews. As a rule of thumb, cohort studies are more efficient than case control studies when the incidence of an outcome is higher than the prevalence of the exposure of interest. For example, you are interested in whether systemic lupus is a risk factor for revision surgery following knee replacement. The incidence of revision following knee replacement is around 2% at 2 years, whereas the background prevalence of systemic lupus is around 0.1%. In this case, since the exposure is rare, a cohort study is more efficient than a case control study. In a separate study, you are interested in the risk of kidney failure and the role of nonsteroidal anti-inflammatory drugs. The incidence of acute kidney injury following knee replacement is less than 2%, whereas the prevalence of nonsteroidal anti-inflammatory drug use is at least 25%. In this case, given the small incidence of the outcome kidney failure, a case control study is more efficient than a cohort study. In cross-sectional studies, exposures and outcomes are measured at the same time. At every time point of interest, a different sample of people is observed. The biggest limitation of cross-sectional studies is the inability to determine incidence and make causal inferences. An example of a cross-sectional study in orthopedics is the evaluation of the association between osteoporosis treatment and radiological findings. Although the percentage of radiological findings may be less common in drug users, conclusions cannot be made regarding protective effect of osteoporosis treatment. We conclude with some questions orthopedic researchers should ask to decide on the appropriate study design. 1. What is the primary hypothesis of the study? Defining the primary purpose of the study will guide plausible study designs. 2. Am I evaluating a novel intervention for which there is no available historical data? If that's the case, an experimental design might be the right way to go. Or wait a couple of years until more observational data accumulates. 3. What is the study budget in terms of money, time, and other resources? Clinical trials require time, resources, and involvement of several individuals. Aims and study design can be adjusted based on the availability of resources.